Usually, when you think about getting a medical diagnosis, there's this expectation of precision, you know?
Right, yeah, like it's math or something.
Exactly. It feels almost like engineering. Like you fall off a ladder, your arm hurts, you go in, and the x-ray shows that jagged white line on the black background.
Yeah, the doctor just points to the screen and says, there it is, broken radius, here's your cast.
Right. It's a beautifully binary moment.
It is. It's either broken or it's not broken.
Whoa.
Very clean.
And there's a profound, a real psychological comfort in that for all of us. We inherently like things to be visible. We want our pain to be categorized and neatly labeled.
Absolutely. We crave that certainty.
But what happens when you step out of that clean binary radiology department and into, well, the chaotic high-stakes environment of a modern hospital emergency room?
That's a whole different world.
It really is. Suddenly, the metaphorical x-ray machine is broken. We are looking at a diagnostic landscape that is just incredibly murky.
Oh, completely. The waiting room is overflowing.
Yeah.
Alarms are blaring down the hall. The staff is exhausted.
Yeah, and the people making the very first critical life or death decisions are operating entirely in a gray area. They're looking at vague symptoms and trying to predict the future.
And predicting the future in a triage setting, you mean it's not just a medical challenge?
No.
No, it is fundamentally a moral challenge.
Mm-hmm.
It's about who gets resources, who gets attention, and who is asked to wait.
Which is exactly where we're going today.
Yeah.
So to understand how to navigate these life and death crises of modern medical triage and the rise of algorithmic healthcare, we actually aren't starting in a modern hospital.
We really aren't.
No, we are starting in ancient India.
Which is quite the pivot, I know.
It is. We are diving into translations of the Mimamsa Sutra, which is this foundational philosophical text codified around 300 BCE.
Right alongside the profound ethical teachings of the Bhagavad Gita.
Exactly. And we are going to crash those ancient texts directly into modern clinical case studies from the UK's National Health Service, medical ethics frameworks, and notes on diagnostic safety.
Yeah, because the mission of this deep dive is to explore one of the most profound questions in human moral life.
Lay it out for us.
Well, it's this. When a specific action is prescribed by your duty, does the consequence of that action, whether it brings you immense pleasure or, say, career-ending pain, release you from the obligation to act?
That is a massive question.
It is. And we are going to trace how a 2,300-year-old doctrine of obligatory action provides a literal, practical blueprint for surviving a broken modern medical system.
Okay, so let's build the foundation for you listening. We have to start with the Mimamsa Sutra.
Right.
This is a school of Vedic philosophy codified by the sage Jaimini over 2 millennia ago. And to put you in that mindset, you have to imagine a world deeply structured by ritual and precise daily obligations.
Yeah, a very structured reality.
So the central question Jaimini addresses is, like you said, massive. Do the consequences of an action dictate whether or not it is your duty to perform it?
And the text answer is an unequivocal, resounding no.
Just a hard no.
A hard no. It's absolute. Mimamsa establishes a vital concept called nitya karma.
Nitya karma.
Right. These are perpetually obligatory duties. The philosophy dictates that certain actions just must be performed, not because of the fruits they might bear.
And the Sanskrit word for this fruit or result is phala.
Exactly.
Yeah.
Phala.
Mm.
You don't act for the phala. You act simply because the actions are intrinsically right.
Wow.
The fundamental premise of Mimamsa is that the consequences of an action belong to the cosmos. The action itself belongs to you.
The consequences belong to the cosmos. I mean, that is a beautifully heavy concept to lay on someone's shoulders.
It is heavy, yeah, but it is deeply liberating if you understand it correctly.
How so?
Well, to fail to perform a dharmic duty, a righteous, required action, simply because you fear a negative outcome, that is not viewed as prudence.
It's not just playing it safe.
No, it isn't caution. In this tradition, it's regarded as a specific, highly destructive form of moral cowardice. It is a transgression in and of itself.
And we see this idea deepened and expanded in the Vedantic tradition too, right? Specifically in the Bhagavad Gita.
Oh, absolutely. There is a famous injunction that you hear quoted quite often, actually.
Let right deeds be thy motive, not the fruit which comes from them.
Yes, that is the core concept of nishkama karma.
Nishkama karma, doing the work without attachment to the result.
What's vital to understand here, though, is that the Gita is not offering you like motivational poetry to make you feel better about a hard day at work.
It's not a poster for an office wall.
Exactly. It is laying down a rigorous, uncompromising ethical position. It demands that you act from pure principle, not from a calculation of personal risk or reward.
Okay, I want to stop right there and push back on this a little bit because it sounds incredibly idealistic.
Sure, go ahead.
It reminds me almost of Newton's third law of motion. Every action has an equal and opposite reaction, but applied to human morality.
Okay, I see where you're going.
Like Newton says, you can't have an action without a reaction. So if we look at human psychology, isn't it true that we are wired to act only because we desire a specific reaction?
That's a fair point.
Like, I am doing this deep dive with you right now because I want the listener to learn something new. I want a result.
Right.
If I am supposed to entirely detach from the phala, the fruit of my labor, won't I just become completely passive? Doesn't this philosophy just breed apathy? I mean, why do anything at all if you don't care about the outcome?
Yeah, so that is the most common and immediate critique of this philosophy. But Mimasa actually anticipates it perfectly.
Oh, really?
Yeah, this is not a passive, fatalistic doctrine where you just sit under a tree and let the world happen to you.
Yep.
It is vigorously, almost obsessively concerned with action. Mimasa demands an intense, continuous focus on the precise nature of what must be done and exactly how it must be done. The doing itself is viewed as the highest expression of human intelligence.
So it's not apathy at all.
Exactly the opposite. A Mimasa practitioner does not retreat from difficulty or complexity. They move towards it with extreme precision and clarity.
Because they want to fix it.
No, simply because the duty requires it. You don't perform the duty to get a reward. You perform the duty because the fabric of reality requires you to uphold your specific role within it.
I see. So it's not about not caring about the world. It's about caring so deeply about the integrity of your action that you refuse to let the fear of a bad reaction paralyze you.
Precisely. That's a great way to put it. And this leads us directly to the concept of svadharma.
Which translates to one's own duty.
Right. This is where the stakes of this ancient philosophy become intensely relevant to modern professions. Texts like the Manusmriti and the Mahabharata explicitly warn, and I quote, "The duty of another is dangerous when performed."
That is a very striking phrase. The duty of another is dangerous when performed.
It really is. It argues that doing your own designated work poorly is actually safer, morally and practically, than perfectly executing a duty that rightfully belongs to someone else.
Wow.
It is a profound warning against blurring the lines of professional and moral responsibility. When you step outside your svadharma, you lack the invisible, foundational context required to bear the weight of that duty.
Which brings us to the collision point. Because this ancient concept of svadharma, staying in your lane, knowing exactly what your diagnostic duty is and isn't, and nishkama karma, acting on principle regardless of the bureaucratic fallout, well, they recently collided head-on with the modern healthcare system.
They absolutely did.
We are moving from the philosophical battlegrounds of 300 BCE straight into the chaotic emergency rooms of the UK's National Health Service.
The modern battlefield. And it truly is a battlefield when you look at the systemic pressures involved.
Let's set the scene for that. The clinical data and historical records of the NHS over the last decade show a system buckling under unbelievable patient overload.
Yeah, the numbers are just staggering.
There simply aren't enough doctors, beds, or hours in the day to manage the sheer volume of human need. So to cope, hospital administration and medical bureaucracy began relying heavily on a systemic change called task shifting.
Task shifting, which on paper looks like an elegant administrative solution to a logistical nightmare.
How does it work?
It involves taking specific tasks that were traditionally the exclusive domain of highly trained physicians and shifting them down the hierarchy to nurses, pharmacists, and non-physician practitioners.
The idea being to free up the doctors for the most complex cases.
Exactly.
So a nurse might be tasked with assessing a patient, making a preliminary diagnosis, and even prescribing medications based on preset algorithmic protocols. Like, if symptom A and symptom B are present, prescribe drug C.
Now, we need to be incredibly clinically precise here because this gets sensitive.
Right, absolutely.
The medical critiques of task shifting are not an attack on the nursing profession. Nurses perform absolutely vital, life-saving duties.
Of course.
They monitor complex chronic conditions, they provide critical health education, they manage intravenous therapies, and they often know the baseline state of a patient way better than anyone else in the hospital.
Right. When a nurse executes their specific svadharma, the system works brilliantly.
Precisely. The danger, the exact peril the ancient texts warned about, arises specifically in the context of triage, and even more specifically when dealing with what medicine calls undifferentiated symptoms.
Undifferentiated symptoms. Let's break that down for the listener.
Sure.
This is when someone walks into a clinic and they don't have, like, a bone sticking out of their arm.
Right, it's not obvious.
They have vague complaints, a fever that won't break, a strange rash, a deep fatigue, maybe some chest tightness. It's a cluster of symptoms that hasn't been differentiated into a specific disease category yet.
Exactly. It could be a common viral cold, or it could be a massive cardiovascular event waiting to happen.
And this brings up a massive concept, the epistemology of diagnosis.
Yes, epistemology.
Which is the philosophical study of knowledge. Like, how do we actually know what we know? In medicine, how do you know that the guy sitting in front of you with a slight cough is actually in the early stages of heart failure?
And that is the crux of it. Most people view triage as just an administrative sorting process.
Right. You walk in, the person behind the desk has a sympathetic conversation with you, takes your name, asks what hurts, and tells you to take a seat.
But true triage is not a conversation.
It's not.
No, it is a rigorous, high-stakes clinical discipline. In areas like pediatric medicine or emergency care, symptoms follow highly complex, often counterintuitive patterns.
Okay.
When a patient presents with undifferentiated symptoms, the assessor must engage in a process of differential diagnosis. This isn't just matching a symptom to a drug on a checklist.
Right.
It is a complex cognitive process of elimination, requiring years of training in pathology, anatomy, and disease progression.
And when you shift that specific task to an untrained eye relying on a checklist, they're simply not going to see the pattern.
No. They will completely miss what experienced clinicians call the red sign presentation.
The red sign.
This is the core of the catastrophe. Picture a patient walking into an urgent care center. To an assessor who lacks extensive deep diagnostic training, this patient appears completely stable.
They look fine.
They're breathing normally, they're speaking clearly, they might not even feel particularly alarming to the person taking their vitals.
But the red sign is there.
It is. Buried within their presentation are subtle, objective clinical markers. Maybe a specific discoloration of the skin, a slight irregularity in the pulse rhythm, or just the way their eyes track.
Wow.
And these indicate a terrifying underlying pathology requiring immediate, urgent escalation.
And if you miss the red sign because it's not on your specific administrative checklist, the consequences aren't just a longer wait time. The consequences are measured in human lives.
Let's connect this back to medical ethics for a second. There is a core ethical principle in healthcare known as justice.
Justice.
But justice in an emergency room is often misunderstood by the public. Justice requires equitable treatment, not equal treatment.
Okay, I want to make sure I'm wrapping my head around this. Let's say I walk into the ER with a really bad sore throat, and at the exact same time, a woman walks in clutching her chest, sweating, and short of breath.
Right.
We both get assessed at triage, but she gets rushed immediately onto a gurney and taken to the back, while I am told to go sit in those uncomfortable plastic chairs for 4 hours. That is not equal treatment.
No, it isn't equal, but it is perfectly equitable. Triage is the specific mechanism that ensures justice is served by prioritizing the immediate threat to life.
The system allocates its finite resources based on clinical urgency.
Exactly. So if we apply the philosophy of Svadharma here, the highly complex duty of spotting that hidden threat, of ensuring that justice is actually served, is the specific Svadharma of a deeply trained physician. When a hospital administration decides to outsource that diagnostic duty to a practitioner who only has a flowchart and a few hours of algorithmic training, the justice of the entire triage system collapses.
You're asking someone to perform the duty of another.
And the duty of another is dangerous. This is not a theoretical debate happening in a university lecture hall. When this specific Svadharma is violated systemically, when the deep cognitive work of a physician is replaced by a protocol, we see horrific results.
The clinical records and case studies document this exact failure. Real people paying the ultimate price for administrative task shifting. I want to walk through these cases because we need to understand the mechanics of how this failure actually happens on the ground.
Yeah, these are tough to hear, but crucial.
Let's look at the first case. A 20-year-old man. He goes to a local walk-in clinic in the UK. He's seen by a nurse practitioner. He presents with a rash and some pain, and he is diagnosed with shingles.
Okay.
He's given a treatment protocol for shingles and sent home.
And shingles, just for context, is a viral infection.
Yeah.
It's caused by the varicella zoster virus, the same virus that causes chickenpox. It typically causes a painful rash that follows a specific nerve pathway known as a dermatome.
Right, so a week goes by, this young man walks back into the clinic, To the casual observer, he looks physically okay, but he's demanding an emergency appointment.
He knows something is wrong.
He tells the receptionist he feels incredibly unwell and refuses to leave. The clinic is fully booked, but the receptionist uses a specific digital triage tool, which we will actually talk about later, and asks him 3 specific questions about his symptoms.
Man.
All 3 answers trigger a red warning in the system. The receptionist overrides the cue and rushes him straight back to a physician.
And what happens when a physician finally looks at him?
The doctor takes one look at this young man, immediately diagnoses septic shock, pulls him into the consultation room, and calls an ambulance to rush him to the intensive care unit.
Wow.
This 20-year-old man never had shingles. He had a staphylococcus infection in pedigo.
That's a highly contagious bacterial skin infection.
Yes. Because it was misdiagnosed as a viral infection by a practitioner relying on a basic protocol, it went completely untreated for a week. That localized bacterial infection breached his bloodstream, resulting in septicemia, blood poisoning.
What is fascinating and terrifying from a diagnostic perspective here is the distinction between a clinical symptom and a clinical sign. This is where epistemology really matters.
Break that down for us. Symptom versus sign.
Sure. A symptom is entirely subjective. It is what the patient complains about. The patient says, I feel unwell, or I have a painful rash.
Right.
A clinical sign, however, is objective, measurable evidence of a disease discovered by the clinician during a physical examination.
So the subjective symptom was the rash.
Yes. The nurse practitioner saw a rash, heard the patient complain of pain, and mapped those subjective symptoms to a common algorithmic protocol. Rash plus pain equals shingles. Pick the box.
But the
physician, possessing the deep svadharma of diagnosis, saw the objective clinical signs of systemic cardiovascular collapse. They saw the early markers of septic shock that the protocol completely missed.
That reliance on the superficial label leads directly to an even darker psychological trap. You see it perfectly in the second case documented in the records.
Yeah, this one is awful.
A 12-year-old girl. She's generally healthy. She hasn't started having her periods yet. Her parents bring her in because she has a fresh blood stain in her underwear.
Okay.
She's seen by a nurse and later even by a junior doctor following the same protocols. She is treated for a urine infection.
Right.
But here is the detail that absolutely stops your heart when you read the case files. They diagnosed her and prescribed medication without ever performing a physical examination.
Which fundamentally violates the entire concept of a differential diagnosis. And we have to ask why that happens. Why would a trained practitioner skip the physical exam?
Why would they?
It comes down to the psychological comfort of the algorithm.
It's the GPS analogy.
Yes, exactly.
Think about when you're driving in a new city using a GPS on your phone. Because the machine is telling you with absolute confidence to turn right in 500 feet, you stop looking out the windshield at the actual road.
You just stare at the screen.
You trust the system so much that people have literally driven their cars into lakes because the GPS told them to.
That is exactly what happens in algorithmic medicine. A differential diagnosis is not just picking the most statistically likely option on a drop-down menu.
Right.
It is a rigorous process of elimination based on gathering physical evidence. But the algorithmic checklist gives the practitioner a false sense of security.
Like the GPS.
Right. The protocol says young girl plus blood equals high probability of urinary tract infection. The machine gives them the answer, so they don't look out the windshield. They skip the uncomfortable, time-consuming physical exam.
And because they didn't look, the evidence contradicted their neat little diagnosis completely. This 12-year-old girl had no symptoms suggesting a urinary tract infection. She didn't have pain when urinating. She didn't have fever. In fact, her urine test came back entirely normal.
And she was seen twice.
She was seen twice for this issue. Both times, the practitioners failed to physically examine her because the checklist told them they already knew the answer.
And the reality of the case.
The devastating reality of this case is that both practitioners completely missed the fact that this young girl was suffering from sexual abuse and traumatic physical injury.
This is where we see the concept of justice failing in the most catastrophic way imaginable.
Yeah.
The svadharma of the healer was not upheld. The duty to investigate, to be suspicious, to refuse the surface-level comfort of the protocol was completely abandoned.
The patient was betrayed by a system that prioritized efficiency over truth.
Exactly.
Let's look at one more case to really cement how insidious this is. A 3-month-old baby.
The toad baby case.
Yeah. The parents bring the infant to their general practitioner, their GP. The baby has a history of vomiting, a rash, and excessive, uncontrollable crying.
Standard distress signs, but alarming in an infant.
Right. The GP, operating within their diagnostic Svadharma, immediately notices a critical physical sign during the exam. The baby's head is unusually small.
Because the skull sutures are closed.
Exactly. For the listener, a baby's skull isn't one solid piece of bone. It's made of plates separated by flexible joints called sutures, which allow the baby's brain to grow rapidly in the first year.
Right, they have to expand.
But the GP notices these sutures have prematurely fused. This is a massive red sign. The GP immediately refers the child to the hospital specialists for a scan.
But when the baby gets to the hospital consultants, what do?
They look at the vomiting and the crying, they look at their statistical probabilities, and they diagnose the baby with a milk allergy.
They diagnosed a milk allergy, completely ignoring the objective physical sign of the closed skull sutures that the referring GP had explicitly noted.
Yes. They just put this infant on an alternative formula. And because parents naturally assume that specialized hospital consultants know best, they trust the diagnosis.
Of course they do.
They don't go back to the GP. 6 to 8 months pass. The mother finally brings the child back to the GP because the baby still isn't well, the vomiting hasn't stopped, and the child's head now looks visibly deformed.
So much time lost.
The GP refers them to the hospital again, but incredibly, the hospital just continues the allergy treatment.
It's hard to even comprehend.
Finally, the child is referred to Great Ormond Street Hospital, a highly specialized children's hospital, simply to investigate this stubborn food allergy. And purely by chance, a neurologist happens to notice the child sitting in the ward during rounds.
A clinician with the correct Svadharma finally looks at the patient.
The neurologist immediately intervenes, overbuilds the allergy team, and diagnoses craniostenosis, the premature fusion of the skull. They rush the baby into surgery to open the skull and relieve the pressure on the brain, but it is too late to prevent the damage. The child is left with severe, permanent developmental delays and physical deformities, looking, as the clinical notes tragically describe, like a toad with eyes popping out of his skull.
These cases are agonizing to recount, I know, but we have to analyze why these failures occur systemically, over and over again.
We really do.
In the philosophy of medicine, diagnosis is an active, deeply investigative pursuit. It requires what the literature calls soft data.
Okay, let me play devil's advocate here for a second because this brings up a massive debate in modern healthcare.
Go for it.
Isn't a junior doctor or a consultant treating a suspected allergy just practicing standard EBM, evidence-based medicine?
Right, that's the defense.
We are constantly told that EBM is the gold standard. You look at the massive data sets, you apply the statistical probabilities, and you follow the protocol. Why is that failing here?
Because there's a vast difference between true evidence-based medicine and algorithmic evidence-based medicine.
Okay, what's the difference?
Algorithmic EBM relies entirely on generalized statistics. A guideline might dictate that 80% of sore throats are caused by a specific streptococcus infection.
Okay.
Therefore, the protocol says, if a patient presents with a sore throat, prescribe this specific antibiotic. It makes perfect sense on a spreadsheet.
Right, it's efficient.
But a human being is not a spreadsheet. A human body is an open, infinitely complex system. Clinical diagnosis requires soft data. Statistics cannot capture the unique, nuanced presentation of an individual.
Give me an example of what the algorithm misses.
Well, algorithms completely miss a crucial concept called oximetry.
Oximetry, let's break that down.
Oximetry refers to the rate of illness growth. An algorithmic checklist takes a snapshot, a single photograph of the patient at one moment in time. Temperature is 101, heart rate is 90.
Just a frozen moment.
Right. But clinical intuition, the Svadharma of a real physician, watches a movie.
Well, that's a great analogy.
They look at how fast the fever is rising, the subtle changes in the patient's breathing over 30 minutes, the specific, unique visual texture of a rash. Algorithms miss subtle comorbidities.
So when you rely solely on rigid protocols, you create massive systemic clinical blind spots.
Exactly. The protocol tells the practitioner to tick the box for urine infection, because that is the most statistically common pathway for those symptoms.
Completely blinding them to the horrifying reality of abuse, because abuse falls outside the standard algorithmic pathway.
And this reliance on rigid checkboxes isn't just an isolated issue in the triage ward. It is fundamentally infecting the entire culture of how medicine is taught and practiced.
Yeah, the historical records dive really deeply into this specific debate within medical administration. The use of pre-printed assessment sheets versus traditional open-ended history taking.
It's a huge debate.
On the surface, I mean, this sounds like the most boring administrative argument imaginable. Who cares what kind of paper the doctor uses, right?
Right, it sounds trivial.
But it's actually a battle for the very soul of medical practice. Do check boxes make doctors faster and more efficient, or do they literally rewire their brains to stop listening and thinking?
The evidence strongly suggests the latter is a profound risk.
Really?
Think about the cognitive process of traditional history taking. A doctor sits down with a blank piece of paper and asks the patient to tell their story. The doctor isn't just acting as a stenographer taking dictation.
No.
They are actively synthesizing information in real time. They are watching the patient's body language, noting what the patient emphasizes, building and discarding differential diagnoses second by second.
It's an active process.
It is a highly complex cognitive dance.
You know, fill-in-the-blank questionnaire requires no special history-taking skill. That is a direct quote from the debates found in the records.
Exactly. When you replace that blank page with a pre-printed sheet or a computer screen filled with required drop-down menus, you fundamentally change the practitioner's focus.
How so?
The junior doctor learns to meticulously fill in the blanks to satisfy the hospital's auditing software. But they fail to develop the cognitive muscles required to analyze the data within their own mind.
Wow. They stop looking at the patient's face, and they start looking at the glowing rectangle in front of them.
Yes. And this technological reliance, this shift away from the patient and toward the protocol, leads us directly into a massive systemic nightmare known as iatrogenesis.
Iatrogenesis, that's a crucial term. Let's unpack it.
It translates essentially to harm caused by the healer. It refers to illness, injury, or death that is directly caused by medical intervention itself.
I mean, most people hear that and think of like a surgeon leaving a sponge inside a patient or a hospital-acquired infection, what's called a nosocomial infection, like getting MRSA from a dirty catheter.
Right, those are the physical examples.
But the records show that iatrogenic harm goes much, much deeper than just physical slip-ups. It includes the profound harm of over-medicalization and misdiagnosis driven by technology.
The clinical literature calls this the passion for diagnosis.
The passion for diagnosis.
It is a phenomenon particularly prevalent among younger, protocol-driven physicians. They have a deep, paralyzing fear of missing something, often driven by the threat of malpractice lawsuits.
Sure.
And they are armed with incredibly shiny, advanced diagnostic technology.
So what do? They overtest.
Exactly.
A relatively healthy person comes in with a minor, vague complaint, maybe a slight occasional headache. A seasoned physician relying on traditional Svadharma would take a detailed history, recognize it as a standard tension headache, give some advice on stress management, and send them home.
Right. Good medicine.
But a doctor, driven by the passion for diagnosis, runs them through a gauntlet. They order MRI scans, CT scans, comprehensive blood panels.
And here's the danger of the open system of the human body.
Yeah.
No human being is perfect.
True.
If you scan enough systems in a perfectly healthy person, you will eventually find something that looks abnormal.
Like what?
The medical term for this is an incidentaloma.
An incidentaloma. I love
Right.
that term.
It's an incidental finding that has absolutely nothing to do with the patient's actual complaint and was never going to cause them harm.
The records use a terrifying example of this, actually. A patient comes in with typical, uncomplicated migraines. The physical exam is totally normal.
Okay.
But the doctor, driven by the algorithm to rule out everything, orders a conventional cerebral angiography.
Oh, wow.
This is an invasive procedure where they thread a catheter into the brain's blood vessels and inject dye just to rule out an aneurysm.
That is extremely aggressive.
Right. The passion for diagnosis takes a healthy individual and gradually transforms them into a patient. And that patient is now subjected to invasive treatments, radiation from scans, and anxiety, all of which put our life at risk for absolutely no benefit.
If we look at this dynamic through the lens of subjective disorders, the iatrogenic danger multiplies exponentially.
What do you mean by subjective disorders?
Conditions like fibromyalgia or irritable bowel syndrome IBS are highly subjective diagnoses. There is no definitive blood test that says, yes, you have fibromyalgia. There is no gold standard MRI scan for IBS. They are diagnoses of elimination.
And because the system is pressuring doctors to move fast and fill out the checkboxes, these conditions are frequently tragically misdiagnosed.
Exactly. A doctor sees a patient complaining of widespread joint pain and chronic fatigue. Instead of doing the deep cognitive work of a differential diagnosis, they quickly tick the fibromyalgia box on the drop-down menu.
And then they prescribe a heavily marketed, expensive nerve pain drug like Lyrica.
But in doing so, They completely fail to look for the root cause. They fail to investigate if the patient actually has severe hypothyroidism, which can perfectly masquerade as fibromyalgia.
Oh, wow.
Or they label a patient with IBS without ever running the test to check for Crohn's disease or celiac disease. The label becomes a trap.
I want to pull this back to the philosophical ethics we touched on at the beginning because this connects perfectly.
Yeah, let's do that.
When you look at medical ethics frameworks, you inevitably run into the philosopher Immanuel Kant. Specifically, Kant's categorical imperative.
Yes, Kant's formulation regarding humanity is one of the absolute pillars of medical ethics.
Remind us what that is.
Kant argued that we must treat humanity, whether in our own person or in the person of any other, always as an end in itself, and never merely as a means to an end.
Let's really unpack that. What does an 18th century German philosopher have to do with a misdiagnosed stomachache in a modern NHS clinic?
Everything. Absolutely everything.
Really?
Think about it. When a patient is rushed through a triage protocol by an untrained assessor, when their complex, lived history of pain is reduced to a pre-printed checkbox simply so the clinic can hit its government-mandated efficiency metrics.
Yeah.
Or when they are quickly slapped with a subjective disorder label so they can be funneled into a profitable pharmaceutical pipeline, that patient is no longer being treated as an end in themselves.
They've been stripped of their complex humanity.
Exactly. They have been reduced to a mere means, a means to clear the waiting room faster, a means to satisfy an auditing algorithm, a data point to generate revenue.
Wow. When the medical system does this, it loses its moral center. It ceases to be a healing profession and becomes a biological processing plant.
And if you want the ultimate horrifying example of patients being used purely as a means to an end, the historical records point directly to the Vioxx scandal.
Oh, Vioxx.
For listeners who might not remember, Vioxx was a massively popular painkiller introduced in the late 1990s.
It was marketed aggressively as a miracle drug for arthritis.
The Vioxx case is cited in the medical literature as the prime example of systemic regulatory capture and the total abandonment of Svadharma.
The drug was eventually pulled from the global market, but only after it caused an estimated tens of thousands of fatal heart attacks and strokes.
Tens of thousands.
The system that was supposed to protect patients, the regulatory bodies, the clinical trials, the medical journals, they prioritized the efficiency of drug approval, the profit protocols of the pharmaceutical industry, and the branding of the drug over the safety of the human beings taking it.
They failed completely.
The Svadharma of the regulator, which is to ruthlessly protect the public, was compromised by industry influence and a shared culture that prioritized getting drugs to market over independent safety analysis.
So we arrive at the crisis point. We have a system that is actively pushing Svadharma aside.
Yeah.
Doctors are being downgraded into data entry clerks, algorithms are blinding practitioners to the red signs, and patients are being profoundly harmed.
The vital question becomes, what does an individual physician do when they are standing in the very center of this systemic failure? They look around, they see the task shifting, they see the misdiagnoses. How do they respond?
This is where the ancient Mimamsa Sutra leaves the realm of theory and becomes a weapon.
A weapon.
Yes, the ancient text demands action. It demands obligatory action, regardless of the fruit it bears.
In the historical records we're examining, we have the direct account of a specific physician, Dr. Srivatsa, who witnessed these exact catastrophic triage failures happening within the NHS.
Right.
This doctor saw the walk-in clinic sending back misdiagnosed patients in septic shock. They saw the Svadharma of complex diagnosis being outsourced to practitioners who simply did not have the training to spot the red signs.
And how did this physician respond to the bureaucracy?
The doctor's documentation is incredibly powerful. They state, and I quote, "I raised my concerns, I documented the evidence, I accepted that the consequences would be whatever they would be."
I accepted that the consequences would be whatever they would be. That sentence is the absolute pure embodiment of Nishkama Karma from the Bhagavad Gita.
It really is. But let's look at the modern legal framework for this first, because it's not just ancient philosophy, it is supposed to be modern law.
Right.
The medical records discuss the duty of candor, specifically CQC Regulation 20 in the UK. This is a strict legal and regulatory obligation placed on healthcare providers.
The duty of candor legally dictates that if a safety incident occurs that results in severe harm or death, like the missed impetigo that led to septic shock, or the tragically misdiagnosed craniostenosis in the infant Kibar, the provider has a strict duty to speak up.
They must be transparent.
They must notify the relevant people, and they must offer a formal apology.
It is the literal legal codification of telling the truth. But as anyone who has ever worked at a massive corporation or government bureaucracy knows, speaking the unvarnished truth to the institution is rarely welcomed. In fact, it is usually punished.
The institution's primary biological drive is self-preservation, not truth.
Exactly, and the records detail the immense, crushing backlash this doctor faced.
What happened?
For challenging the administration, for explicitly questioning the ethics and safety of having nurses prescribe drugs without the necessary diagnostic framework to rule out complex pathologies, the doctor faced intense, punitive sanctions from the health service.
The institution tried to silence the critique by punishing the critic.
And here is the absolute brilliance of viewing this modern whistleblower struggle through the lens of ancient Indian philosophy.
How so?
When the core principle at stake is patient safety, calculating the risk to your own career, your own reputation, your pension, or your own comfort isn't just irrelevant. According to Mimasa, that calculation is morally dangerous.
Because the moment you pause to calculate, will I get fired for reporting this misdiagnosis?
Yes.
You are attaching yourself to the fruits of the action.
Yes.
You are worrying about the fallout. You are letting the cosmos dictate your morality.
Precisely. The svadharma of the physician is to protect the patient. The svadharma is to ensure diagnostic accuracy. The action speaking out, documenting the systemic danger, fighting the flawed algorithmic protocol, belongs entirely and solely to the doctor.
And the consequences.
The consequences, the punitive sanctions, the hostile work environment, the professional exile belong to the cosmos. You do the right thing simply because the universe requires that the right thing be done.
Okay, I hear that. And deeply on a moral level, I admire it.
Yeah.
But I have to be real for a second. It is incredibly easy for you and me to sit here in a comfortable studio and talk about the beauty of philosophical detachment.
That's fair.
It is an entirely different reality to actually live it, to watch your hard-earned career burn down, to face investigations and sanctions from a monolithic, multi-billion-dollar health service. That takes a massive psychological toll.
It really does.
How do you fight a system that large without just becoming a martyr? Because if you just speak up, get crushed, and get fired, you aren't in the hospital anymore. You can't help any more patients. You lose your ability to practice your svadharma entirely.
That is the pivotal, central question of applied ethics. How do you act without being destroyed?
Right.
And the physician in these records didn't just complain and accept martyrdom. They didn't just point out the flaws in the algorithm, write a strongly worded letter, and walk away.
What did they do?
They used their deep clinical intelligence to build a solution. They translated that ancient ethical duty of obligatory action into a highly practical, modern technological tool.
Which brings us to the culmination of this whole diagnostic journey, the MAYA system.
MAYA medical advice you access.
After facing all this institutional pushback, the doctor didn't retreat. They sat down and ruthlessly analyzed the data.
They looked at a study of 700 patients who had rushed to consult a doctor in an urgent care setting.
And they realized something structurally shocking about how patients utilize the healthcare system. Out of those 700 panicked patients, only a tiny fraction, about 24%, actually needed a physical clinical examination.
Meaning they had a physical lump that needed palpating, or a complex rash that needed a trained eye, or a laceration that needed stitching.
Exactly. Meaning that the vast majority of patients seeking emergency or urgent care, over 75%, did not actually require the physical presence of a physician to resolve their immediate concern.
Right. Most of them were terrified, and they just needed to know one fundamental thing. Are my symptoms dangerous?
Do I need to be sitting in this crowded ER waiting room, or can I safely manage this fever at home?
So the doctor created the Maya app. They took the thousands of possible medical complaints and narrowed them down to just 12 common presenting symptom categories. Things like fever, cough, headache, abdominal pain.
But instead of creating a rigid, simplistic protocol that just says fever equals take paracetamol, Maya breaks those core symptoms down into highly specific subclasses.
It introduces clinical nuance back into the triage system.
It replicates the svadharma of history-taking.
Exactly. Let's look at how it actually replicates a doctor's brain. If you select fever, Maya doesn't stop there.
What does it ask?
It asks, is the fever high, moderate, or mild? Is it associated with chills and rigors, meaning are your teeth chattering? Are you alternating between feeling incredibly hot and freezing cold?
Oximetry.
Yes. Is the fever steadily going up every single day, or does it spike every 3 days like clockwork.
It uses a combination of these subclasses and applies a sophisticated color-coded risk system to identify those hidden red signs before the patient even leaves their house.
This is a critical intervention against the modern, incredibly dangerous trend of internet self-diagnosis.
We've all done it.
You have persistent headache, you search the symptoms online, and within 3 clicks, the algorithm has convinced you that you have a rare, inoperable brain tumor.
The clinical records explicitly warn about the dangers of self-diagnosis. It fundamentally lacks perspective.
A panicked patient searching Google cannot run a differential diagnosis. They do not have the clinical training to rule out the 30 benign things that cause a headache, like dehydration, tension, or eye strain, before jumping to the catastrophic 0.01% possibility.
But May doesn't diagnose. That is the genius of its design.
It doesn't.
No, it refuses to give you a disease label. It doesn't tell you what disease you have. It simply assesses the complex pattern of your symptoms to tell you when you need to seek professional triage.
So it acts as a safety net.
Exactly, bridging the massive gap between a patient's natural anxiety and the objective need for clinical safety.
It is giving the svadharma of initial assessment back to the right people. It empowers the patient to understand the severity of their own body's signals safely.
And by doing so, it reduces the blind panic that currently floods our emergency rooms with non-urgent cases.
If you can keep the non-urgent cases safely at home with peace of mind, you preserve the hospital beds, the nurses' time, and the highly trained doctors for the people who actually have the red signs.
It is a tool designed to ensure that justice, equitable treatment can actually function in a reality of scarce resources.
And it perfectly aligns with the modern progressive healthcare goal of person-centered care.
By utilizing validated psychological tools, like the patient activation measure, the PAM, which clinically assesses a patient's knowledge, skill, and confidence in managing their own health and healthcare, MAIA treats the patient as an active, intelligent participant.
It treats them as an end in themselves, returning to Kant's imperative, rather than treating them as a passive, helpless recipient of algorithmic processing.
And if we zoom out and look at the MILA system through the lens of everything we've unpacked today, it is the ultimate practical synthesis of the MILASA call to action.
It really is.
This doctor didn't retreat from the overwhelming difficulty of the modern broken NHS. They didn't just accept the fatalism of the system is too big and too corrupt to change.
They moved toward the difficulty with absolute surgical precision. They documented the medical failures, they accepted the putative consequences from the cosmos, and they built a systemic solution to protect the humanity of the patients.
They perfectly executed their svadharma.
So take a step back and look at the incredible intellectual and moral journey we've taken today. We started with the 2,300-year-old Mimamsa Sutras, reading texts that demand obligatory action regardless of the personal cost.
We move through the Bhagavad Gita's profound call to abandon our desperate attachment to the fruits of our labor.
And we took those ancient, lofty, seemingly abstract concepts and dragged them straight into the tragic, high-stakes, bleeding-edge reality of modern hospital triage.
We've seen exactly how relying on rigid algorithmic checkboxes, how outsourcing this svadharma of complex diagnosis to untrained assessors blinds the medical system to the subtle red signs.
We've seen how that blindness literally costs lives, turning healthy people into victims of iatrogenic harm. And we've seen how one doctor's stubborn, principled adherence to their own duty birthed a tool designed to protect patients from the blind spots of an overwhelming bureaucracy.
It leaves us with a rather profound paradox to consider as we close.
What's that?
Well, we spend so much of our time right now in the media and in technology sectors debating the limits of artificial intelligence in healthcare. We argue endlessly about whether a machine, a super algorithm, can ever truly replace the empathy, the intuition, the oximetry, and the diagnostic brilliance of a human doctor.
Right.
But after reviewing this history and these clinical realities, perhaps the real question we should be asking is whether modern medical bureaucracy, with its rigid protocols, its task shifting, and its pre-printed assessment sheets, has already turned our human doctors into algorithms.
Oh, wow.
If ancient Indian philosophy teaches us that true duty requires conscious, difficult, principled action, then perhaps the greatest medical innovation of our time won't be a new piece of technology or a faster AI.
What will it be?
Perhaps the greatest innovation will simply be a return to the profound, unautomatable moral courage of the individual healer.
That is a heavy, necessary thought to carry with you the next time you walk into a clinic or an emergency room. We want to thank you so much for joining us on this deep dive. We hope it illuminated the unseen forces operating behind the triage desk and gave you as much to think about as it gave us.
It's been a powerful one.
And as you go about your week, maybe take a moment to examine your own life through this ancient lens. What is your svadharma? What are the specific duties in your own life, your own family, your own field that require your action regardless of the consequences the cosmos might throw at you?
Good questions.
Until next time, keep diving deep.